Hello. Today, Sarah Scott and I will be discussing the history, development, implementation, and future of VBP initiative metrics. I'm going to begin with a quick overview of healthcare regulation and how value-based care initiatives developed from the traditional fee-for-service models. In 1965, Medicare and Medicaid became part of the Social Security Act passed by Lyndon Johnson. The idea of this program was to protect the growing and aging economically disadvantaged population in the U.S. from rising prices of healthcare costs as modern medicine became the standard level of care. Within a few years, it became clear the current regulation on hospitals were not sufficient to ensure Medicare and Medicaid recipients were receiving equal care with their private insurance counterparts. The first government-regulated review committee was developed, URCs, which were intended to monitor hospital performance and ensure Medicare and Medicaid patients were not unfairly treated. The URCs were eventually replaced by experimental medical care review organizations because URCs did not have any authority to regulate hospitals they found to be ignoring industry standards. The EMCRs went through a variety of changes during the late 20th century, and each iteration improved upon the last and gave this organization more power to regulate hospital performance. Leading into the 2000s, peer review organizations became the Quality Control Group and the newly formed CMS, a government-run organization that now manages Medicare and Medicaid patients. PRO initiatives eventually became VBP initiatives in the early 2000s. In the 1990s, the VA hospitals' post-op mortality rates were significantly higher than private hospitals, so the NSQIP was introduced to encourage better practices for safer post-op treatment in VA hospitals. This was extremely successful and became implemented in non-VA hospitals in the coming years. Several quality improvement organizations were then created by both government and private insurers to regulate industry standards among hospitals. VBP eventually became the umbrella term for initiatives started by these foundations. Now we're going to discuss how VBP metrics are created. Currently, VBP metrics are developed based on several principles set forth by the CMS focused on improving patient care quality and cutting costs. Unfortunately, many of these metrics have little background research done before being implemented. Unlike the first VBP initiatives at VA hospitals, most metrics now only have 1 to 2 years of data before rolling out, and they are rarely formally reevaluated for accuracy or continued usability. This has caused some hospitals to take hits for VBP performance outside of their control. Currently, the CMS does not provide a lot of data to the public on how they evaluate these metrics, so this will hopefully be changed in the future. As you can see on the left, almost 70% of healthcare reimbursements are tied to health insurance payouts. However, the CMS does not give much input to providers or hospitals on how metrics will be evaluated. Currently, it's very difficult for hospitals who serve a very unique patient population to do well under current VBP metrics. Health insurance companies are required to negotiate contracts with hospitals, so this is not as much of a problem in the private sector. Now I'm going to talk about some of the current VBP metrics being used. Currently, most CMS metrics are focused on patient safety and satisfaction. There's a large push for a quality of care that was introduced with the Medicare and Medicaid passage and community engagement. Additionally, the CMS is working to promote cost-cutting measures by focusing on promoting industry standard practices and rewarding positive clinical outcomes. The private sector does not have as much transparency with their metrics, but based on research, private insurance metrics closely align with the CMS, but they are much more focused on cost-cutting practices. There are many programs under the CMS that are working on VBP initiatives, including the IPSS, which is the major player in CMS goals of promoting patient safety and community engagement. The Hospital Readmission Reduction Program and Acquired Condition Reduction Program are more focused on patient safety and improving mortality rates, as well as costly hospital readmissions that can really have a negative impact on patient health. The ESRD is one of the major new players in the CMS VBP program and is focused on reducing mortality rates among end-stage kidney disease patients, which is known to be a costly and very deadly disease to treat. So like I've said before, there's very little data on private insurance VBP metrics. However, I was able to find a few. Currently, Cigna is rewarding physicians who choose the most accurate PCSK9 inhibitor for their patients instead of relying on a preferred drug. The Arkansas Blue Cross Blue Shield is tying more and more physician reimbursements to their own VBP initiatives, which will expand in the future. Forbes also estimates that almost 50% of commercial insurance reimbursements are tied to some kind of VBP initiative, with no plans to decrease this in the future. VBP is clearly a successful program. It's done a great job of improving patient outcomes, promoting safety, and reducing mortality rates among some hospitals. It's also done a great job of reducing operation costs and promoting physicians to look at the best treatment option for their individualized patient instead of relying on their own preferred treatment. It has had a few issues though. It's created some opportunities for physicians and hospitals to cheat the system and gain better reimbursement strategies. These loopholes will need to be cleared up before this program is expanded. It's also created additional administrative work for both hospitals and insurance companies because the amount of data collected each year must be analyzed by somebody. In addition, precision medicine is becoming more popular, and as it does, VBP initiatives will need to keep up with this and make sure physicians are not penalized by choosing unique or new treatments that may not always be covered by insurance companies yet to promote their best patient health. Thank you for listening. Now Sarah is going to talk about current opinions of healthcare leaders on VBP metrics and where they're going in the future.
All right, so when we are looking at how metrics are being evaluated, electronic health records provide the main source of data, and additional sources are coming from patient-reported outcomes and provider and staff surveys. And this is just an example of a provider and staff survey that compared patient safety in different healthcare settings. So this data is used to calculate a score, and these scores are compared using this AHQR tool. The score and this tool is made public so that consumers and purchasers can pick the healthcare providers with the highest scores, and physicians are also able to determine how they are doing in relation to their peers. One of the drawbacks is just the discrepancy between what is being measured, how it's being measured, and how scores are being calculated. When we're looking at how physicians are perceiving this shift towards value-based purchasing, there's a fear of losing the intrinsic motivation to be a doctor as focus is really shifted towards money. And so these statistics just reflect how physicians are skeptical of value-based purchasing and the efficacy of these implementations. And so there's also a worry that areas of care that aren't necessarily being measured or scored are going to be neglected as resources are shifted towards the areas that are being measured. And there's just also a lot of time and money that physicians and providers are having to sacrifice in order to accurately document and report. And these are some factors that are influencing physician scores, but physicians are not necessarily able to influence these. They don't have full control over patient outcomes or how well or the degree to which practices and hospitals are implementing these quality measures. And so these factors that are out of their control are still affecting their individual scores. So when we're looking at administrators, two of the biggest challenges they're facing is the lack of technical and financial support. So they may not decide to implement value-based purchasing aspects and adopt the quality improvements just simply due to this lack of support. And also there's just the challenge of coordinating this shift towards a different delivery of care and getting everybody on the same page. So when we're looking at it, purchasers, which would be insurers, they're the ones who are most directly and to the greatest degree benefiting from value-based purchasing, just because cost is being minimized and quality, which is determined by their metrics, is being maximized. So they're also able to use the information from the scores to determine areas that need improvement, so they can customize the incentives for providers and for hospitals. And lastly, the financial risk is being shifted from insurance companies to providers. An example is in the past when for a hospital readmission, the insurance company would absorb the cost of that, whereas now the provider may not reach their threshold for reimbursement and their paycheck may be affected by this hospital readmission.
All right, so now I'm going to talk about the changes that we've seen with value-based purchasing metrics, what value is, and where VBP could go from here. The total performance score is part of the determining factor of Medicare compensation that a hospital receives. It's based on clinical care, safety, person and community engagement, and the efficiency and cost reduction. In the fiscal year of 2019, the TPS across all participating hospitals increased from 37.4 to 38.1, with more hospitals having an increase in Medicare payments than those that had a decrease, which indicates we've improved both quality of care and value. Now, the improvement hasn't been the same across the board. Change in Medicare payments ranged from 1.59% decrease to a 3.67% increase, with the average payment adjustment being just a positive 0.17% increase. Among all hospitals that had an increase, the average was a 0.61% increase, while the average of all decreases was a 0.39% decrease. So what is value? During my research, I came across a quote that I really liked. Broadly, value-based care means care where the clinical benefits outweigh the risk and the cost. We face situations every day where we must determine the value of different actions. In each of those decisions, we ask ourselves if the benefits outweigh the costs, and it's no different with healthcare. In this graph, we're comparing healthcare spending per capita to life expectancy among many different countries across the world. As you can see, the United States spends almost $3,000 more per capita than the next highest spenders, but is not among the best in life expectancy. The idea of VBP is meant to focus on metrics that will increase the value of our care by decreasing costs and yielding better results, or in this specific case, longer life expectancies. But where does the patient's opinion fit into VBP? Going back to our original quote, I believe the end of it shows the importance of the patient's opinion. It says, the challenge is an individual's perception of value isn't based on universal definition. Value is not always universal. Patient opinions are critical in defining value for each individual patient. While improving outcomes and decreasing costs are our end goals of VBP, we are entering a profession of treating patients. Appropriate patient satisfaction should always be a central focus to the medical care that we provide. Now, what is the future of VBP? Where will it take us? While it seems to be picking up steam after beginning just 11 years ago with an increasing number of healthcare groups focusing on VBP-style care, although minimal, we have seen improvements in participating hospitals. The future may depend on where healthcare goes in general. With an upcoming election, this could mean that healthcare could change, although it doesn't seem to be slowing down anytime soon. However, based on what Sarah has said, it seems that many physicians don't prefer VBP, and some feel that it could negatively impact their relationships with patients. As Ashley pointed out, it provides opportunities to cheat the system. Expansion of VBP will require changes along the way. In an article from the JMA forum, Dr. Ashish K. Jha suggests 3 important metrics to help VBP become more successful. Those metrics are Stronger incentives focus on few measures important to the patient and transparency. For the stronger measures, he suggests increases or decreases that could be as high or low as 5 to 10%. With the measures important to the patient, he gives examples of mortality rate, patient experience, and functional status. And finally, with the transparency, we've seen that there's a risk of pointing patients towards less efficient doctors as they seek posted prices for different procedures. Those doctors with lower prices could be lower because they've received less money or less payment from Medicare. Regardless, it will be interesting to see what changes are made and how they affect the value of our healthcare system. Thank you for listening, and we hope you've enjoyed our presentation.